Today, I have an interview with a PA working in a niche that I'm sure most people don't even know exists.
What?
I am talking about a very niche practice within the specialty of craniofacial surgery, where they help people who have gender dysphoria by offering facial feminization and facial masculinization surgeries. Whether you personally agree with people transitioning genders or not, it is still a fascinating interview listening to him describe the different surgeries they do and seeing how medicine is changing and evolving and how new specialties come about. It really speaks to how medicine grows and adapts. Hi, my name is Michelle. This is my channel. Thank you so much for joining me today. On this channel, I love to uncover all of the different things that PAs and NPs can do. If you like what I do and feel like I'm bringing valuable content to people, then please help support the channel by hitting that subscribe button and, of course, sharing it with other people who may find this information interesting. All right, let's head into this interview and learn about these incredible surgeries and what it's actually like to work in this specialty.
My name is Jack. I am a certified physician assistant. I graduated in 2019, kind of fell in love with the operating room. I actually did a rotation in cardiac surgery and was like, oh, this is great. PAs get to do so much. You get to get your hands
Yeah.
really in there and do a lot. I was lucky to kind of network my way into a job. It was a transplant in an MCS center and program. So they had a mechanical circulatory support program. So VADs, transplants, the whole thing. So that was a great place to start my career. I learned a ton and was able to do so much in the operating room. In fall of 2021, I transferred over to the cardiac program. I was thinking about what else I could do as a PA. I wanted to stay in surgery, but was just thinking of other options. I wanted to kind of expand my talents and my skills, maybe in another specialty, and was actually fortunate to kind of land the job and role that I'm in now through the help of a recruiter. And believe it or not, it was on LinkedIn of all places. So yeah, now I'm in craniofacial plastic surgery, primarily working alongside one surgeon with another PA here in the office. And we are primarily doing facial feminization and facial masculinization for trans femme and trans masc patients.
I'm sure you never thought that you would work in what you're working in now.
I had no, yeah, there was no plans to kind of to land where I am now, but yes, yeah.
Yeah. Okay, so let's dive in and talk about what you do. And so your general overall specialty, I guess we could say, is cranial facial surgery, but you guys niche down even more specific. So can you talk a little bit about that?
FFS, and I'll abbreviate facial feminization surgery as FFS.
I don't blame you.
Okay, yeah, is primarily a kind of group of procedures. FFS is more like a bucket, and then you just throw the procedures into the bucket depending on what the patient's anatomy is presenting to you or what they want out of their operation. So there's a craniofacial component where typically masculine facial features carry brow bossing. The eyebrows are down, the hairline's way back. So all of those things are kind of more of a craniofacial component. There is some orthognathic component to it, meaning either the chin is underprojected or too far forward and the vertical height is too tall. And then, of course, there's an aesthetic component to it as well. So making sure the patients are getting the feminized features that they want.
And so what is your role and how involved are you in the actual surgical procedure?
That's a good question. Yes, I would encompass it as all perioperative medicine, meaning pre-op to in the OR to post-op care. So I see the patient in pre-op, where we go over post-op care, go over the medications they could take after surgery, and then we sit down with the surgeon one more time. Of course, we're in discussion with the patient before surgery about, what to expect, things to get done prior to the operation. I assist in the operating room, so I will be essentially just first assist the entire time. I do help and assist in some of the wound closure, and then in terms of post-op care, there's 2 post-op appointments depending on the scope of surgery. But yep, do all the post-op care. That's kind of general breadth of my role here. So
Yeah. And so are you Monday through Friday in the operating room?
I share duties with another PA here in the office, and we divvy it up by every other day. One of us is in the OR, so I'm Monday, Wednesdays, and we alternate on Fridays. So every other Friday, I'll be in the operating room first assisting. But yeah, on the days that I'm not in the OR, that's kind of more for post-op care and kind of behind the inbox. So kind of more of a administrative clinical duty, if you will. and also just addressing any sort of preoperative issues that we're having with patients at that time.
Every specialty is different. Sometimes I'll talk to PAs who are working in a specialty, and they will actually be the first provider that anyone sees when they come into the practice, and they'll do all the fact finding, get the information, and then they'll have a follow up with the physician. How does it work in your office? Is the first contact with the patient, the initial appointments, always with the physician, or do you guys handle that?
Primarily, their first visit to the office is for their consultation with the surgeon, and I am a part of that process. Typically, how it works is we will go over the medical history with the patient, meaning myself and the patient, and we like to do some photos for the consultation, and then we all sit down, right? So it's the doctor, myself, and the patient go over what the patient's expectations are of the surgery, what they maybe particularly want, and then after they are done with the surgeon, I sit down with them and I go over kind of the expectations of post-op, like what that looks like.
Wow, you really get to know everything about this patient, because it's not like the physician sees them and learns all about them and decides what to do, and then you're just kind of getting this patient cold for pre-op and post-op. You've been through the whole process with them, so that must be kind of cool to be able to follow the patient that much and know that much about them.
Yeah, it's a very different like kind of side. It's a very personal side of medicine, because I think a lot of what medicine is now, and especially in primary care, other internal medicine kind of areas where the inbox just bogs you down, right? And it can be overwhelming, and you don't feel connected to your patients. It feels like
Yeah.
you're just churning and burning. So it is nice. I get to focus a lot on them. I get to give them the care I think that they deserve, make them feel at ease and comfortable about the whole process. I think that that's something we do great here. So.
What does your work schedule look like? Like, roughly what time are you usually getting to work and leaving every day?
Always an important thing to discuss, especially in the clinical world. It's like we always want to know the schedule, like when am I going to get time to breathe, right? So if it is a Monday through Friday gig, I do take call. We alternate call, meaning myself and the other PA here in the office. I always kind of do an apples to oranges thing with like the call here and the call that I used to experience in cardiac. Like cardiac was like sirens on, like let's go. Here it's kind of like a little bit more of a light hum kind of in the back of your ear, and it's more patient centric care, right? Like I get one patient, the one that's post op that day, they stay one night at the surgery center, and I'm kind of, when I'm on call, I'm dealing with that, right? It's not like I got 5 to 12 patients on the floor that I'm dealing with or
Right.
something. It's not too bad in terms of the call load. And yeah, Monday through Friday on the OR days, we start at 7:30, so I get there usually around like 6:45 to 7. We operate out of an outpatient surgery center, and so I get there, try to get there a little bit early, just get things kind of set up. And then we do come back to the clinic and do consults. If you were in the OR that morning, then we try to get that PA out at like 4:30 p.m. And then the mornings that I'm not in the operating room, I start here at 9. And then generally around 6 p.m. is when I make my way out. So
If you guys are coming back to the clinic after the OR in the morning, like, how long do these cases typically last?
they are on average about 6 hours in duration. So
Okay.
it's long surgery. Even open heart doesn't last that long, right?
Yeah.
Depending, it's more of like a bread and butter case. If it's more complicated, it can. But yeah, it's pretty long surgery.
And then when you're in the clinic all day, like, how many patients do you normally see on a clinic day?
Yeah, so my clinic days will be in the morning, do 2 post-ops. The first post-op's reserved for general wound care, taking out suture staples, that kind of stuff. Do some other things as well. They got a big cast on their face, so we do a hair wash for them because they can't wash their own hair because unfortunately the cast will get compromised and all that, right? So we wash the hair for them, and which is something they don't teach you in PA school. I tell every patient that I'm like, I didn't learn this in PA school, so I'm just going to do my best job. So I'll do those 2 in the morning, and then in the afternoon, the other PA and I will alternate on the consultations. So yeah, that's kind of how we cadence the days that I'm not in the operating room. And so I'll take the last consult, which will generally last until about 6 p.m. or so.
So how many patients does that on average work out to be usually?
Oh, that's about 5 patients.
Oh, okay.
5.
So you have one of those unicorn jobs where you actually get to sounds
Yeah,
like you
yeah,
get
yeah.
some time with patients.
Yeah, for sure.
Which
For sure. Absolutely.
which is how all medicine ideally should be and stuff. But that's
Yeah.
great. So can you give people an idea of what, like, an FFS surgery entails?
What that kind of entails typically for at least most of our patients is advancing the scalp, because I mean, as you can see, my hairline's not doing so great, but but advancing the scalp down, right, as much as we can. Sometimes patients will need to kind of iron that out later with some hair transplants, because we can advance it only so much that the anatomy will allow us to.
But how do you pull the scalp forward? Like, it doesn't seem like there's any extra stuff to pull forward.
Yeah. That's a good question. Yeah. So you do have to essentially detach it from the skull. So you kind of undermine that tissue, and that loosens things up a little bit. Now, anatomical differences for everyone, right? Some of those scalps
Right.
can really move, like you can really mobilize it. Sometimes, like, despite the fact that you've undermined a lot, it still just doesn't want to go.
And then the rest of it, is it, like, actually, like, peeling the face off? Or how do you get to all of the
Yeah. So
stuff you
we
need to
make a
do? Yeah.
big pericranial flap. So this flaps down. When I say we're undermining the scalp, this is all flapped down, so
Okay.
you can undermine the scalp. But yeah, we flap all this down. We contour the forehead, and then we snug all that back up, close all that
Okay.
up for areas where patients are maybe a little volume deficient. So, like in the cheeks, under eyes, sometimes up here on the sides. Those all can be accomplished with fat. So we use autologous fat from the
Okay.
patient, and can graft it into the face, which provides them with good volume. Sometimes in the lips as well, if patients want a little bit more volume there.
Yeah.
So yeah,
And
that's
do you
how we
guys do
accomplish that.
rhinoplasties sometimes
Yeah.
if people
hmm
in the thing? Okay.
Yeah, so usually what happens is when you set the forehead back a certain extent, the nose sometimes gains projection because you're setting this portion of the
Ah,
forehead back. And so almost always, if we're doing a forehead, we are going to almost always do a rhinoplasty with that as well.
okay.
Yeah.
And then I guess the last thing, the Adam's apple, like, if it's really prominent on men, can you guys do stuff with that as well?
That's correct. Yeah. So if that is a little more on the prominent side, we do reduction for that. In masculinization, you can actually make an Adam's apple. And so you have, the platysma, which is kind of that band of muscle, more kind of like a fascial structure, if you will. So that's kind of a big sheath over the top. So once you kind of open that up, then you have some of the strap muscles that are there. And then, yeah, right underneath that is, I mean, you can see all the cartilage structures. It's really cool, actually. It's
Yeah.
really cool procedure.
Hmm.
It's tough because it's such a small space, but yeah, it's a cool
Yeah.
operation.
So you say when they get this surgery that the face kind of gets put in a cast? Tell us a little bit about that and, like, how long recovery normally takes.
The nose does get a cast. It goes kind of across the nose here and then goes up and over the forehead. And that is all fixed down with tape and stays on until their second post-op appointment with
Mm.
us. And we do put two plastic splints inside the nose. So a lot of ENT procedures and even rhinoplasty in general, you will have splints in there. And this helps with the swelling. It helps kind of keep all the structures together as it's kind of initially healing, and those come out on their second post-op along with the cast coming off of the face. Recovery in general, I would say most patients are pretty kind of ironed out and feeling good about things at around 3 months, I would say. There's pretty robust swelling in the chin and jaw. That's pretty common with orthognathic surgery as well, as there's just a big swelling response there.
Yeah.
Still, this does take sometimes like up to a year to show full resolution, but I would say most patients by 3 to 6 months are pretty happy.
What are the things that you really love about your specialty? And maybe even things that might have been a surprise that you didn't know that you were going to love?
I think something that I really love about my work now is being able to really focus and attend to a patient's needs and answer their questions, and even hop on the phone with them for like 15, 20 minutes and just kind of talk it out. That's what I really do love. I think the biggest challenge for me in the role initially was, of course, pivoting specialties, right? I think there is this kind of daunting thing about, like, oh, well, I learned all this in cardiac and now I
Yeah.
got to learn all this new stuff. And there are kind of the general principles that transition across surgery in general, but it's very nuanced in my role now. And so it was really kind of like starting from scratch.
Did you have any more you want to say, either good or
Oh,
challenges of it?
yeah, the challenging part. Yeah. So, being that it's aesthetic, there are some challenges to that in terms of making sure a patient's expectations kind of meet what we're able to provide them. We can give you a general idea of where this is going to land, but we can't predict the exact outcome of this operation. And we can almost guarantee we'll give you a great outcome, but it's not going to be something where we can do kind of millimeters of nitpicking. And so just learning communication styles, learning about how patients kind of communicate. I've learned a lot about how I communicate to patients too.
Our looks are so personal to us, and so much part of our identity that I think anyone that's considering working in any aspects of aesthetic medicine, for me, it feels like not necessarily a landmine, but it's just a field that is rife for people to be dissatisfied if, especially, you don't manage their expectations going into it.
You're right. I mean, especially in this kind of world of social media, has really kind of challenged a lot of people, especially the younger generation. Why don't I look like this, right? And so showing pictures of where they want to land, but it's like a picture of Margot Robbie or something like that,
Yeah.
and you're just like, we can land you in a place that will allow us to land you.
A lot of times people are who are susceptible to being swayed or having some depression or just don't feel good about themselves, and they think this is going to fix it, and then they go and do this drastic surgery. Do you ever have that where you feel people walk in and you're like, I'm not sure that you understand or that you are really the right candidate for something like this?
So there's a whole part of our pre-op screening of when patients have started HRT, if they are on HRT, if they are working with a therapist or mental health provider. We try to gather that information so we have an idea of that before going into consult with them. And then the consult really does tell us a lot about where a patient's at, just their demeanor, the way they're communicating things, their affect. That's the beginning of the consult. It's just like, tell us about you. Like, what's
Right.
your story? Some patients are very open and just like you could tell they're very comfortable. Of course, they are dealing with some gender issues that need to be addressed, but they are very open and communicative. And then some are just a little flatter. And so, usually with those, we try to get a better sense of like, is this the decision that you're ready for? And are you ready to make that? And we do also, in terms of our scheduling, it's not that we schedule surgery and then a month later they're in the operating room. There's months that'll go by. So, we kind of keep a close eye and tabs on those that we need to, and not necessarily red flag them, but maybe give them a yellow flag of like, let's just keep a close eye on this patient. They have surgery booked at this time, and just kind of communicate with them a little bit better just about where they're at.
Yeah. What are you seeing for results? Are you getting like a lot of feedback from people and about changing their lives for the positive?
Oh, big time. Yeah, I think that's also another pro of the job that I maybe forgot to mention previously. It's just how rewarding it is. It's much more like of a harmonious type procedure. Of course, the aesthetics are like, this looks great, but there's also just this part of patient's reaction and their quality of life that just like just like goes through the roof. And so there's an element of fulfillment and reward of what you're doing.
I feel like there's probably an artistic or creative feeling in the job you do.
Yeah, I mean, that is kind of like definition of aesthetics, right? Is like
Yeah.
it's a philosophical thing. And also the beauty is in the eye of the beholder kind of thing, right? But that's why we're very thorough on the objective stuff, so we can land them in a place that we know would get them there in terms of feminizing the face.
Just in general, what kind of personalities do you think would do well in this kind of specialty?
Team player is big. I think attention to detail. There's a lot of intricacy to what we do, but also there's a lot of hand holding in what I do. Patients with gender dysphoria, they're dealing with a lot. And so guiding them through the experience of surgery can be challenging. So just having that level of patience and having that understanding that, okay, they're going through something that's not anything that I've experienced, but I can understand why they're anxious and why they're feeling this way. So that
Yeah.
level of understanding is kind of crucial.
We haven't talked about money yet. Give some people some idea of
Yeah.
if this is a higher paying or lower paying specialty.
I won't give you my specific, but I will tell you the range on the job posting, if you will, was 185 to 230.
So it's a higher paying specialty. Like even in the surgical specialties, you were in, I think, cardiothoracic, but was it a little bit of a bump up or was it kind of lateral for you?
Yeah. No, it was a bump up for sure. I think the years of
Yeah.
experience helped. Of course, all of this stuff's negotiable at the end of the
Yeah.
day. I think a lot of people have a hard time advocating for themselves. And so I think just try it. I don't think
Yeah.
it ever comes across as like anything other than like this person is just trying to advocate for themselves. So.
Right. Yeah. Because it's not personal, it's just business. It's your business to negotiate your salary. It's their business to offer and negotiate back and things. And that's just
Yeah.
what it is. But it's just hard for people to talk about money, unfortunately. But it's
Yeah.
definitely important.
I will say, like, I don't just do the clinical stuff, right? So being in private practice means there's a whole slew of other responsibilities, right? So it's not just like showing up in the OR and just doing the job. There's a whole admin side of what I do that's not clinical. And so I think that if anyone's looking or potentially interested in some sort of role like that, just understand that you will be asked to do other things that aren't clinical, and just willing to accept that responsibility and understand that, I think, is kind of, step one.
Yeah.
So
Yeah, cool. So if somebody is thinking about this and thinks this sounds interesting to them, either your niche or just cranial facial in general, like say they're already a practicing PA, or maybe NP. I think NPs, their hang up is usually a lot of times they don't have the surgical training, so they may have to go get, I can't remember what it's called, uh, RFN or something. Anyway, where
oh,
they get
RNFA, yeah. Yeah.
RNFA, yeah, where they get extra training in the OR. But be that as may, if somebody's looking to move into this and they're already practicing, any advice you would give them for maybe trying to prepare themselves or start doing some pre-learning before they look at one of these jobs?
I think if it's something specific to gender care, gender affirming care, there's a ton of roles out there. It's not just craniofacial, but there's
Yeah.
a
Yeah.
whole bottom surgery component, right? Phalloplasty,
Mm,
vaginoplasty. There's a ton of surgeons out there doing that. But I think if you're looking at kind of resources, I like to carry kind of like wound care books. Just if I run across like a weird kind of wound care thing, I'm sure everyone has this, right? It's Bakerman's. It's that lab study book. So we get pre-op labs for patients, although they're pretty basic labs. It's always good to kind of refresh your memory on that stuff.
Are there any kind of like national societies or anything that you think is gives some good information or might be
I
worth joining
think
or looking at?
AASPA is good. American Academy of Surgical Physician Assistants, they're great. They have good kind of forum-based stuff as well. So if you're
Yeah.
trying to get out there in the field, you could, post that you're interested or working in a certain area or whatever. There's a plastic surgery group as well. I primarily just am through AAPA, so
Yeah.
I renew my membership every year with them because they have pretty good CME resources and stuff.
And if somebody is watching this, they're pre-PA or they're in their just starting PA school and they haven't got their rotations lined up yet, are there any other specialties that you think might be helpful for them to get?
I think trauma would be a good one. Orthognathic or maxillofacial, although it's pretty rare subspecialty or specialty to work in. There's a whole component of plastics that you got to think about, right? Because it's plastic and reconstructive. A lot of in the hospital skin flaps and grafts and all these things that are very complex. But yeah, if there's like an interest, I think those avenues would be a good place to start.
If you're looking back now, would you advise somebody if they're a new grad, not whether they can get this opportunity or not, but do you feel just as a new grad that this would be fine to start in as your first, entry into the career, or would you really advise they do something else first?
I would say if there is an opportunity and, there is a surgeon willing to take you under and kind of, teach you the ropes, I think one of the great things about a new grad is that they don't carry the bad habits that they may have somewhere else. And I don't want to say bad habits, or I should just say habits, right? That
Yeah.
you learn that sometimes can be difficult to transition out of when starting a new role somewhere. So I would say don't ever shy away from it. I even went into the whole application period of my new grad life with this idea that I would never land a job in cardiac, and I landed a job in cardiac. You have to be tenacious about it, and you have to kind of set the bar high for yourself.
And I think, like you said, doing your best to make sure that it's going to be a mentoring and learning type situation as a new grad, no matter where you land. That's so
Mm.
important. Okay. Well, any last thoughts or things you want to say about your specialty, or just a plug about why people should consider this as a specialty?
I don't want to plug anything. I think there's pros and cons to every place you're gonna work. I'm not here and gonna say like, oh, my job is just rainbows and unicorns the whole time. It's challenging, but I think any job will carry those challenges. I think most about what's going to be telling about your, kind of professional acumen and your professional stamina, if you will, is how you're able to kind of adapt to those challenges that come your way and how you're able to kind of grow from them. I think always have the mindset of growth in any opportunity that you eventually are going to try to pursue, because you don't want to hit cruise control. It's just not going to be a very fun thing. You'll just be counting down the hours at work.
Okay, great. Well, thank you so much. I really appreciate your time and for telling us all about this unique specialty.
You're so welcome.
If you want to learn more about plastic surgery in general as a specialty, then check out this video. Thanks for joining me. And as always, take care, stay sane, and I'll see you next time on the Medicine Couch. Bye.